Lockdown is something that has kept us all in hold, changed our lifestyle. 3 months ago, nobody thought we'll be sitting like this and doing webinars. Nobody even imagined that we'll be doing all these things. Now I've lost track of the number of webinars. In fact, the most interesting that I learned over the last 1.5 months was how to develop an Android app. It's nothing very great. So I'm learning something outside medicine. It's very interesting. And we also picked up an online consultation about which I will be dealing with shortly. Now, this teleconsultation, when we start talking about it, seems so far away. It seems pretty far away. And this particular picture kind of summarizes the whole thing. What it means is that this actually is a picture that's taken by me. Photograph was actually taken by me. As I was walking to my hotel close to Heathrow, I found a flight landing, and this is the picture that came. I think teleconsultation kind of summarizes what happens here. It's so far away. We don't know what is inside, and we are trying to reach out and do what is to be done. Now, I will tell you what I have been doing over the last 1 month. The last 1.5 months of the lockdown has been a revelation in a lot of things, and I will try to take you through what we have done and how things have been going on. So what I thought, I will take you through a typical scenario that happened in my clinic or in my consultation online. 38-year-old son of my cardiac patient on a COVID lockdown says, I am just too stressed sitting at home, and the BP seems to have gone up. His father is hypertensive, my patient, who's on a regular home BP monitoring. So he took his BP machine and checked up his BP, and his BP was 150/100. He got alarmed, and he called me and said he needs a consult. So we thought we will do an online consultation, and what I thought I will do is tell you how we go about doing an online consultation. Now, this is what we have evolved. This does not involve any other specific platform. Surprisingly, good or bad, we started doing an electronic medical record in my clinic over the last about 6 years. We have had records, and our records have been there for all the patients who are already existent. Now, this guy is new, but still, when he calls our clinic number for an appointment, what happens is he calls for an appointment. My secretary picks up the phone, and the most important person in an online consultation, the way I work, is my secretary. So the online consultation is explained by my secretary. And once she says that the online consultation is there and the patient understands it, we tell them to check their BP as close as possible, get a BP check. In fact, we have been big proponents of home BP monitoring over the last 2 to 3 years. Most of our hypertensive patients have their BP checked at home. And interestingly, not only that, most of these patients also have their blood pressure checked at home, chart it and bring it to us. We'll show you a copy of our chart also just now. So they are asked to check BP, and if they have done any investigations, for other patients, we tell them you send your investigations, your other consultations, whatever you have met, any doctor you have met since the last consultation, send it across, and then the secretary links to the patient. So this is my secretary and my patient, all are here. And what happens is the secretary is the link. She calls me, make sure I'm ready, calls the patient, it's ready, and through a WhatsApp, we are linked. Once we are linked, and I start talking to the patient, the secretary goes off, and then I have a chat with the consultation with the patient, ask them, talk to them. I'm sure most of you will agree, the moment you talk to the patient within the first 2 to 3 lines, most of you have your diagnosis in place. This is what happens. All the rest of the questions are all adding things and adding here, adding there and everything. And once you finish your consultation, what I do is we email a prescription. And once we email a prescription, then I link the secretary with the patient, and what they do is they talk the other modalities, and our payment modality has been direct from the patient. What we use is Google Pay, or we use a direct bank transfer to our accounts. At the end of this, when does the patient visit the clinic? The whole thing is online consultation. This whole scenario that you have seen is an online consultation. And when does the patient visit the clinic? Now, suppose I feel that the patient is going to need to come to me, like for instance, a specific investigation like an ECG or an echo, but I think that is going to make a difference. I will give you some scenarios about how well you can manage your online consultation during the course of my talk. But here what you'll notice is the clinic consultation is only for an investigation, and my technician comes all decked up and dressed like this, and she does all this, and she takes an ECG and an echo for the patient with as minimal contact as possible. And we have timed our investigations in the clinic so that we give 30 to 40 minutes per patient, so that any given point of time, one patient comes with one attendant, both of them wear a mask. The moment they come in, they use a sanitizer, come in, does the echo, and then they get out. We don't come into physical contact with the patient at all. We are just there, and this is how we are working in the clinic. We have done about 200 patients in this way, and I think patients are also very happy. In fact, the outstation patients are extremely happy, and the system seems to be working pretty well. Now, having done this, how do you define hypertension in the clinic? How do you define hypertension in your patient's house? Because both are not the same definitions. Now, if you look at the American definition on the right and the British definition on the left, there is a slight difference because the Europeans are a lot more conservative and they have stuck to 140 by 90 as the definition of hypertension. But in that case, the home blood pressure is 135 by 85. The American definition is much simpler, much clearer. 130/80 in the clinic, 130/80 for home BP monitoring. And if you're going to take an ambulatory BP, the daytime average is also 130 by 80. So it makes it much simpler if you remember 130/80. But that is going to make more and more patients hypertensive. I still think that the view is going to be much simpler if you start medication at 140/90. Don't start medication till you're 140/90. So if our patient has got 140/90, what do? He's got 140/90 and then he got 150/100. This is what the BP he told me. So what do? Do I have to start him on a medication based on these guidelines, or what do we have to do? Which if you are on a teleconsultation, you don't get to see the patient physically, so you don't know what's happening. You can talk to him and assess his anxiety status. Everything can be done pretty much. But what this says is much like what we should be doing in clinical practice. This is the American guideline very clearly. If your blood pressure is between 130/80 and 160/100, you can do a 3-month trial of lifestyle modification. So this is pretty good. I think this should be the panel, and this should be the panel that we should be following. And this is most important. And if your ambulatory or your daytime BP is more than 130/80 at the end of 3 months, then we consider starting medication. Now, if the BP, home BP is low, then what you do is probably call it as white coat hypertension. The clinic BP, the patient has come to your office, is going to work. Now, here we are talking about a slightly different scenario. None of these guidelines envision that you'll be doing so much of teleconsultation and monitoring. So these guidelines are not going to apply exactly. So what are you going to do? So home BP is 150 by 100. Now there is another scenario also between 120 to 130 systolic and 80 minus in diastolic. Here also you do a lifestyle modification and try to follow up these patients. This is just for completion for other patients who come to your clinic also that I said. If we're talking about non-drug patients, now what did we do for this patient is going to correspond to what is to be done. Whenever the blood pressure goes more than 140/90 on more than one occasion for a patient, he says that it is 150/100. Before the consultation, we ask him to check his BP again, and again it was 140/90. We do the basic blood investigation. The reason why I say do this basic blood investigation, like look at your sugar, your lipid profile to assess his risk factors. You also look at his renal parameters, which are very important on a urine analysis, and at least try to get an ECG. Now, for this, the patient need not come to your clinic. The patient can go to any nearest lab, go ahead and do these investigations. The main reason for this panel to be done initially, I think, is because you need to know the renal parameters. Because a lot of times, patients with mild renal disease get into trouble because we miss these investigations. So any hypertensive, first time on diagnosis, please don't start medication without checking your renal parameters. Another important thing is your serum electrolytes in this. Because once you start medication, when you want to start medication, these are very, very important. This is very, very important because what happens is these patients have to be dependent on their electrolytes, and based on that, you have to start your medication. That is important. Your urine examination, if you're doing one, if you want to do an optional test, you do an albumin creatinine ratio, which is much more accurate than this, especially in a diabetic patient. So we have done these investigations. What we did for our patients, we asked for baseline investigations. He did these investigations, and once he did these investigations, he felt that everything was normal. So normally, if you're not doing this in your clinical practice, when you do a clinic blood pressure monitoring, remember your patient has to be seated for a minimum of 5 minutes, and you take 3 readings, 1 to 2 minutes apart, and the average of the last 2 is your correct blood pressure. This is how the blood pressure is taken in the office. If the readings are more than 10 millimeter different, you probably have to take additional readings because there's a lot of anxiety component, and the patient is probably moving not very cooperative. So this is how the office blood pressure is supposed to be taking 3 readings. The last 2 average is going to be the most important thing. Now, how do we manage the blood pressure in the clinic? Now, this is AC, is our Ashwin clinic, and this is the chart we give for our patients for monitoring blood pressure. Now, how do we monitor blood pressure? We tell them, check your blood pressure in the morning on waking up, before coffee, tea, or before going out for a walk. What this essentially means is, wake up, go to the toilet, come back, and do it. The reason is, if your bladder is full, your blood pressure is going to be high. Empty your bladder, wake up, brush your teeth, come back, and check your blood pressure. Evening, similarly, check it before dinner. What we are trying to do is you usually take your antihypertensive drugs after food, after your breakfast or after dinner. So before food, you are at the trough of the drug level in the body. So what happens is you check the blood pressure during the trough of the drug in the body, and you try to pick up the blood pressure at that time. You will know what is going to be the maximum blood pressure. This is going to be very accurate. The second thing is when you look at the early morning blood pressure, you're trying to pick up the early morning surge also to some extent. So that way it works very effectively. And when you get the patient, you give him a certain instruction. Like you tell him, you sit with the back supported, legs uncrossed, and elbow rested on the table. Now this has a particular significance because this is how the patient says, this is my resident from Apollo First Med, and this is how you sit. You sit with your back supported, your feet flat on the ground, don't cross your legs, and your elbow should be rested on the table. Now this is an mercury apparatus, but you can use an automatic apparatus, which is the best and which is what is going to be available in the future. The reason for this is, if you're going to lie down and check blood pressure, the supine blood pressure is higher by 8 millimeters. If you don't support your back, the diastolic BP actually goes up by 6 millimeters. And if you cross your legs, the systolic BP again goes up by about 2 to 6 millimeters. So you try to avoid all these three things and give them these clear instructions. And what we tell them is, we ask them to sit close to the table with your back supported, legs uncrossed, elbow rested on the table. And after 5 minutes of rest, record the first blood pressure. 1 minute later, take the second BP. And 1 more minute later, take the third BP. Ignore the first reading. Your average of the second and the third is your correct blood pressure. You also note down your pulse, because if your pulse is very high or very low, you know probably that reading is wrong. So that also gives additional information. Now, apart from this, you also see a comment column here. What it means is, apart from the two readings, if the patient notices some unusual symptoms at some other time, you ask him to record the blood pressure at that time, and then what he does is he also records the BP and notes down what is the comment. Like, let's say he's got a headache or a giddiness or something, you note down what happens. And if you give an SOS tablet, like an amlodipine or a nifedipine, he notes down that also at that time and notes it down. The target blood pressure for home BP monitoring is going to be 130/80. Now, this is quite different from what I said. I said 140/90 to diagnose hypertension. But remember, when you start treating your patients, your threshold for starting your medication is 140/90. But the target blood pressure is 130/80, accepted by both the Europeans and the Americans. And when you start diagnosing hypertension also, 130/80 is a much better blood pressure to target and treat. The reason for that is simple. If there has been an Indian study also, this is the Mumbai cohort study for about 5.5 years of follow-up study. When you had one as a baseline for systolic BP of less than 120 to 129, the mortality from death and stroke from IHD and blood pressure was 1.16 was the hazard ratio, when the systolic BP was 120 to 129. And between 130 and 139 in India, it was 73% more. So clearly for Indians also, the target seems to be 130 blood pressure. At least there is an Indian study to quote that seems to be showing this particular data. This is a published article from the American Journal of Hypertension as old as 2009. It's a published article. Now I'll give you the same scenario. We had the same guy with 150, 100. Now what are you going to do? We have asked this guy, what should you do? Should you put him on an alprazolam and say, relax guy, take it easy? Or you want to do a lifestyle modification? You want him to come to the clinic in a lockdown? Or you want to do a home BP monitoring? What I told, I have given you in the panel. I have asked for a lifestyle modification and home BP monitoring for this guy. Home BP monitoring, the technique and how we do it, we have clearly mentioned to you. What is this lifestyle modification? Because this is going to be very important, because this is something we can stress. And one of the most important components of teleconsultation or a home BP monitoring is that you have to spend time with the patient, because the patient otherwise is not going to be satisfied. Because if you're going to be physically seeing, you talk to the patient for 5 minutes and he's satisfied, you can send him. But in a teleconsultation, you're going to be seeing the patient, unless you see for a minimum of 10 minutes, the patient is not going to be satisfied at all. So you have to spend some time with the patient. And what do you do for 10 minutes in hypertension? You know that the BP is high. What else are you going to do? Lifestyle modification, what you have not been stressing. Wonderful opportunity for you to stress the lifestyle modification. Kiran, I have a question for you. Now, one of the commonest things that I found out with most of the people during the lockdown is they miss this. What is this? This is a healthy, sumptuous, beautiful breakfast. This is how they did breakfast, with all the beautiful idlis, the masala idlis, the vada, the podi idli, the chutney, the sambar. Very sumptuous, looks pretty good. Now, how many of you have breakfast? I know that a lot of people are not really having breakfast. People have said they don't have breakfast and they want to lose weight and all these things. I'm coming to losing weight, we'll come to later. But what is the significance of having breakfast? If you look at this particular study published in 2019, you'll notice that if you don't have breakfast, the hazard ratio for a cardiovascular disease is 1.87 compared to 1 as normal, 1.87. The hazard ratio for stroke actually is 3.39. Significant increase. And the overall heart disease hazard ratio is 1.59. So remember, if you're not going to have breakfast, you're going to get into trouble in terms of cardiovascular disease and also in terms of stroke. So tomorrow, please all of you start having a good breakfast. I didn't say a very heavy breakfast, but have some breakfast. Breakfast seems to be having some benefit. I don't want to talk about intermittent fasting. I'm sure some of you might have questions about intermittent fasting. I will come to that later. I've switched off my question and answer panel. I will come to that at the end of the discussion. Also, please don't forget, have your breakfast. But when you talk about lifestyle modification, the first thing that hypertensives expect you to talk about is salt restriction. Not too much of salt restriction, but one thing I keep telling is avoid the excess salt. What is the excess salt? Avoid the salted chips, salted cashews, the pepper, all the chaat that you keep having, and don't add any salt from the table. Just a little bit of lesser salt, not more than that, not without salt. Without salt, salt actually is an acquired habit, and if you don't have the salt, you're going to get yourself into trouble if you don't have any salt at all. So be a little cautious with the salt intake. And are you able to see my pointer? I think it's, yeah, I think it's see. Fine. So it's be cautious with your salt intake, avoid excess salt. The second thing that keeps coming in this is to avoid binge drinking. This is taken from the European Society of Cardiology recommendations, and avoid binge drinking. Now, whenever I talk about drinking, I'm sure all the people who have heard my hypertension have seen this hypertension talk, I've seen this panel. Now, this happens to be a collection of miniatures. This happens to be in the drawing room of my house. I think it's very enticing, especially with the fact that all the liquor shops are closed. But in Tamil Nadu, good news is that Supreme Court has allowed you to open the shops, so people be happy. But this is a collection from my father, and what I want to draw your attention to is two important sayings. Now, whenever anybody listens to my talk, the first thing is whenever they listen to this, the greatest enemy of man is alcohol, but the Bible asks us to love thine enemy. In fact, whenever I give a talk, people start clapping at this. They're so happy when they listen to this. But one more to this, if you want to see, there are two panels here. When you drink, you sleep. When you sleep, you don't sin. And when you don't sin, you go to heaven. So let's all drink and go to heaven. This beautiful saying. My dad collected this. He passed away 3 years ago, but his collection still remains, and this remains in the drawing room of my house. Now, how much to drink? Not more than 2 drinks per day for men, and for women, it's not more than 1 drink. Just plain binge drinking is the one that creates a little bit of problem. The other thing is the dietary consumption of plenty of fruits and vegetables, and have these Mediterranean type of diet with a lot of nuts, and avoid red meat, all those things. And overweight, obesity, bring down your weight. The simplest way to explain weight to a patient, when you do an online consultation, whatever his weight is, tell him height minus 100 is going to be your maximum weight that you can have. If you're going to be less than that, it's fine. If not, probably you should be cutting down on your weight. Waist circumference is difficult to measure even for a person who knows it. It's quite difficult. But in an online consultation, there's no way you're going to talk about it. Next is going to be the exercise. How much of exercise? For a normal person, 30 minutes of exercise 5 days a week is 150 minutes. If you're going to be jogging, 25 minutes 3 days a week, you want to come to about 75 minutes. Or you have to go ahead with a high intensity weights for twice a week. Because the other days you let the muscles rest so that they don't get overburdened. Now, if you're hypertensive or diabetic, if you're having a disease, it is going to be 40 minutes, 3 to 4 days a week. Now, remember this, all the hypertensive or a borderline hypertensive patients should be doing 40 minutes of exercise and not 30. 30 is for prevention, 40 is for treatment. That is going to be important. Walking briskly is what is a moderate intensity exercise. Water aerobics, bicycling, tennis, ballroom dancing, we're not going to do that. General gardening, all these things can come as moderate intensity exercise for you in clinical practice. Now, smoking has to be stopped. There's no doubt about it. I'm sure all of us know about smoking, so I don't want to dwell and bore you too much about how much you smoke and how you're going to be smoking. Now, our patients, how long do you monitor this home BP monitor? Now, this is going to be tricky because there are different guidelines, but the simplest thing is you do a morning and evening blood pressure that we say, and they say for at least 3 days initially or 6 to 7 days prior to the clinic visit. This is very, very interesting and important because if you're going to do 6 to 7 days prior to your clinic visit, it saves you trouble because sometimes you have these patients. I'm sure you have seen these patients. You ask them to buy a BP apparatus, more trouble than benefit. They check the BP each time, it's like they run back and call you. This happens very often. So you try to avoid that scenario And what you try to do is tell them to check the BP in the last 1 week prior to visit, or at least 3 days prior to visit. Now, in this case, our patient had a first-time diagnosed hypertension, and when he started looking at his blood pressure, it turned out to be 130 to 137 maximum, and a diastolic pressure was normal, and the heart rate was about 80 to 90. There's some anxiety component involved. So what happens if his blood pressure was not like this and it was 140 by 90? That is going to be a different scenario. At 140 by 90, you still don't have to start medication. You can still stick to lifestyle modification. Give him a 3-month trial, tell him if he's overweight, lose weight, and do the entire set of lifestyle modification that I said. Therein, you can still try to manage it. You can, because you have time. You have 10 minutes to talk to the patient. You can consult him, you can convince him, and you can definitely make patients understand. What I found out with online consultation is this: the more you talk to the patients, 10 to 15 minutes of convincing on the phone, and when you especially, what we do is we call them through a WhatsApp video call. So when the patient sees you, and if you're genuine and if they're able to understand, it makes a big difference in clinical practice with online blood pressure monitoring. And when you look at this panel, this is going to how you're going to diagnose the hypertension. In white coat hypertension, the first initial blood pressure is high, and then subsequent 24-hour BP and home BP monitoring becomes normal. True normotensive, both are normal. And sustained hypertension, when both are high, there is a reverse hypertension, white coat hypertension, called a masked hypertension, where the clinic BP is normal, office blood pressure is high, or occasional blood pressure is high. I mean, a few points about that in online consultation. I will tell you what the problems are, and we will look at it. Now, when you look at white coat hypertension, you must always remember one thing. Like if this patient, we said, had an initial high blood pressure and subsequently the blood pressure was normal. So possibly if he had come to the clinic and I had noticed that blood pressure, we'll be diagnosing him as white coat hypertension. The reason for why I'm pushing this is only for one reason. It's quite common. The incidence is 13 to 35%, meaning 1/3 of new hypertensives are going to be white coat hypertensives. But the problem with these white coat hypertensives is not as benign as it seems, because 1 to 5% of these patients are going to become hypertensive over the next year. So every year, 1 to 5% increases. So if you're going to look at 5 years, even if you look at 3, it's going to be 15% of these white coat hypertensives is going to be hypertensive. So over 10 years, 30% becoming hypertensive. So you have to follow up these patients. And even in these white coat hypertensives, please insist on lifestyle modification and also emphasize them to keep checking their BP periodically, because blood pressure, when it goes up, unless it is going to have a major catastrophic event, is going to be missed till a very long time. So be careful. And in the long-term outcome, this is a very old study, 1994 itself, we knew that compared to a normotensive, the white coat hypertensives do not fare as well. The dippers and the non-dippers, when you do an ambulatory blood pressure, nighttime increase in blood pressure, they do the worst. They fare the worst. And the dippers fare better. But what I want you to understand, between a normotensive and a white coat hypertensive, white coat hypertension does have a bad prognosis. So don't ignore white coat hypertension. Be a little cautious. Emphasize lifestyle modification, because once you stress on that, long term, they are better off and they're going to be happy about what's happening. If you still have a doubt, ambulatory blood pressure is the choice. Now, if you're going to do an ambulatory blood pressure monitoring, it's going to be tough during the COVID days, but it's very easy to sterilize this equipment, because most of these are done with plastic material. You can easily sterilize them. Use a spray of any kind of this disinfectant, and you're going to be there to see these patients. You can do an ambulatory BP monitoring and probably hold it out for about 3 days and start using it again for a next patient. So 3 to 4 days, I'm sure you're going to get rid of all the fomites that have been transmission that you're going to be looking at. So I think it's reasonably safe to do an ambulatory BP, but when you come into contact with the patient, be careful. You're trying to avoid consultation and contact with these group of patients. Now, the ambulatory blood pressure has also been an excellent predictor of hypertension-mediated end organ damage, and there are several papers to it. It doesn't correspond to our data, but I just wanted to tell you that it is a very useful tool, and I will tell you some patterns of ambulatory blood pressure. Even most of these patients, when you notice that the clinic or the home blood pressure is doubtful, ambulatory BP turns out to be absolutely normal. The red is the elevated blood pressure. All the greens are the normal blood pressure. And like this guy had, it's an absolutely normal blood pressure in 24-hour ambulatory BP. The dark panel here, the gray one that you see in the middle, is a nighttime blood pressure that this patient has had. Now, what next are we going to see? We're going to look at, suppose this patient turns out to be hypertensive persistently and he continues to have a blood pressure that is more than 160 and it turns out to be a little unwieldy, we're not able to manage him, then we start looking at drugs. Now, this is the NICE guidelines of 2019, the last guideline that I'm able to come across. This clearly states hypertensives less than 55, more than 55. I think this is a very beautiful classification. It says if the age is more than 55, the first choice is going to be a calcium channel blocker. And if your age is less than 55, ACE inhibitor or a low-cost angiotensin receptor blockade. If it doesn't work, next step is to combine these two drugs. And if it doesn't work, probably add a diuretic. Now, for a general practitioner doing a practice, and if you're doing an online consultation where you've not seen the patient, you don't know about a lot of things. But online, you can still ask for peripheral vascular disease. You can ask for certain things like claudication. You can ask for asthma. You can ask for several contraindications also. But I remember what I said. I said you must look at the urea creatinine electrolytes because most of the labs are there. So if you do an urea creatinine electrolytes, then what you're going to do is you can start an ACE inhibitor or an ARB in a younger person. But the safest drug, which I think for a general practitioner, if you don't want any mishaps, is probably the calcium channel blocker. For an online consultation, I would suggest you either start an angiotensin receptor blockade or a calcium channel blocker, both of which are safe. And depending on what is going to be a target, like suppose your blood pressure is too high, you can even go in for a combination therapy. The reason is the non-adherence rate. If you look at it, when you give one drug, the non-adherence is 10%. For two drugs, it's going to be 20%. And for three drugs, it's as high as 40%. So if you want to think, you want to bring a blood pressure by 20 millimeters of systolic and 10 millimeter diastolic, generally, apart from the newest or the latest angiotensin receptor blockade drugs, most of the drugs bring down the blood pressure by about less than 10 millimeters of mercury. So what happens? If you want a double-digit reduction, you have to use a combination. And when you use a combination, you're going to probably combine a calcium channel blocker with an ACE inhibitor or an ARB. And that is going to be the best and safe combination to do. And home BP monitoring, like I said, is going to be emphasized and do. Now, how many of you have been exercising regularly? And how many of you have been going for the ice cream like this? There's an old lady who's caught between these two. She's trying to exercise and also trying to do the ice cream. How many of you have done this? I have another question. How many of you have not only done this, have lost weight? How many of you have gained weight during the COVID? And how many of you have been doing this up and down phenomenon or the yo-yo phenomenon that keeps happening? There was a very interesting study called the Western Electric study, which looked at exactly this. And they found out the 25-year crude risk of coronary death with weight loss, weight gain, weight neutral, and weight cycling, which is where the up and down weight, you gain 2 kilos, lose 2 kilos, gain 2 kilos, lose 2 kilos, which is what most of us seem to be doing anyway. If you are losing weight, there is a 70% 25-year crude risk of coronary artery disease. Also, if you lose weight, what happens if you gain weight? Is it good or bad? Interestingly, it's only 15% if you gain weight. Not too much. If you gain weight, the point is it is 15% useful. What if you're weight neutral? It is better than that. So if you're not doing anything great, you try to neutralize the weight and keep the weight of the same, it's about 14%. But what about this weight cycling? People who keep going up and down like most of us do, that is the worst. This weight cycling, the incidence seems to be the worst, and it seems to be 26%. So mind you, if you want to gain weight or lose weight, gain weight or lose weight. If you can't do, if you're going to do the yo-yo phenomenon, please don't do that. Stick to the same weight. That is better off than doing this weight cycling. This is just for you because this is in Corona, COVID, whatever you're doing. With the lockdown coming down, be careful about your weight also. I'll give you a second scenario. There's a 65-year-old female, hypertensive, well-controlled, generally on 140/90. There's no housemate during the COVID time, so did a lot of housework, but she stopped working. Now she says that she's feeling very, very, very tired. What are you going to do? She comes to you. She called my secretary. My secretary picks up for an online consultation. He asked for a blood pressure, and she took her blood pressure and said it's about 126/76 or 80. And this is what happened, and she feels very, very tired. The usual drug that she's taking, a combination of telmisartan with amlodipine, is one of the most common drugs used here, 40 milligram and 5 milligram, and a chlorthalidone 6.25 milligram after lunch. She's postmenopausal, and she's also taking a combination of vitamin D and calcium. What would you normally do? Normally, during this phase, we will be looking at chlorthalidone, and the first thing that we'll be thinking of is look at the urea, creatinine, and electrolytes, because we are worried about hyponatremia, very common cause of fatigue. Now, this is not there. This patient did not have hyponatremia. The urea, creatinine were normal. The electrolytes were also normal. So we asked her to monitor the blood pressure. And surprisingly, apart from that simple day of about 126 or 130, most of the blood pressures were actually on the lower side, except in the early morning, sometimes the blood pressure was on the higher side. What is this? We are having a clear case of variability of blood pressure. Now, this variability of blood pressure is very, very important. You'll notice that a lot of patients come to you. Once you start online consultation and start this monitoring of blood pressure, BP variability is going to happen very, very often. Herein, the maximum systolic BP reached was a very strong predictor of stroke. It's very important that you should remember that try to cut down the blood pressure most of the time. And there are three different patterns in which it goes up. One is the masked morning hypertension, which happens with heavy drinking, excessive physical activity, cold stress, insomnia, obesity, and endothelial dysfunction. There is a masked daytime hypertension, which is usually related to smoking or excessive coffee drinking. Also, this seems to be creating a problem. A lot of dietary factors also working. And there is a masked nighttime hypertension, very difficult to diagnose. And those patients have a nighttime elevation of blood pressure, wherein unless you do a 24-hour BP, you're not going to diagnose. So the three different patterns of masked hypertension that keep happening. Now, I just show you some 24-hour ambulatory BP monitoring of these masked patients. Now, this patient had a daytime average of 136/84, not too bad. And this nighttime blood pressure is 135/85. Normally, you should have a 10% fall in blood pressure at night, which is missing, and the nighttime blood pressure is as high. So you probably add another drug at night and try to mask this nighttime drug. And there are certain drugs which specifically work at night, and like some ARBs are beneficial, and they specifically bring down the nighttime blood pressure, or the non-dipping pattern becomes a dipping pattern in these group of patients. There's another patient who also had a blood pressure which was consistently normal in the clinic, but unfortunately, the patient started developing left ventricular hypertrophy after 1 year. But the home BP was pretty much clinic BP. Each time she comes about once in 2 or 3 months was absolutely fine. She used to go to a general practitioner, keep checking periodically, and this is what was happening. But what happens here is she used to come for a consultation between 2 and 3 in the afternoon. The blood pressure was absolutely normal. But at other times, the nighttime blood pressure was going, and there was a non-dipping pattern. The dipping was just 4%. It's a typical non-dipper, and whenever these patients go for a left ventricular hypertrophy or an end-organ damage that is not explained by the blood pressure, 24-hour BP and even the home BP comes in handy, because you ask them to check at multiple times, you can still diagnose this 24-hour BP fluctuations and variability of blood pressure. Now, this patient, the reason why I put was for two things. The BP variability is of multiple varieties. I think all of you should be aware of this, that there is a short beat-to-beat variability that could happen. Short-term 24-hour variability, normally the blood pressure is in a trough in the morning when you wake up, starts going up as you increase the activity through the day, peaks around 10, 11 o'clock, then it starts coming down. There is another smaller peak around 4 to 5 o'clock in the evening, and the nighttime BP starts coming down. Nighttime, definitely there is a 10% fall in blood pressure. Is it within the day 24-hour variation? Now, there is also a visit-to-visit variation or a day-to-day variation of blood pressure. The day-to-day variation is what we try to do and find out during a home BP monitoring. There is a visit-to-visit blood pressure. So what our patient actually had is very peculiar and what is called as a seasonal variation. Now, this is very important because I never thought it was happening in India till I actually spoke to a doctor who's looking after an elderly or an old age home where she monitors blood pressure. She says that during summer, there are a lot of these patients who dehydrate themselves, there is salt loss, and the blood pressure comes down, and there are plenty of drop attacks. So you please monitor your patients carefully during summer. You will notice that the blood pressure comes down, and what you do is reduce the dose of antihypertensive drugs. This was peculiar phenomenon seen mostly in the West, and it seems to be happening very much in India, and we don't seem to be recognizing it. There is a very clear seasonal change also. And actually in our patient, what happened was this happens as a seasonal change. When I actually probed the patient, she said, last year also in summer, I had the same problem and you reduced the drug. I never realized that. Then she told me, you reduced the medication, this is what happened. And this seems to be a seasonal change in blood pressure, which I think you should be aware of. It's not peculiar to telemonitoring. Telemonitoring, pick it up a little more clearly, but this can happen in clinical practice. And all of you remember, in summer, if a patient complains of fatigue, reduce the dose of antihypertensive drugs. And those patients who have these high variability, if you look at the quartiles of 1, 2, 3, 4, more the variability in the mortality, the heart disease, the stroke, the end-stage renal disease, all seem to be much higher if the fluctuation or the variability in blood pressure seems to be very, very high. There have been several studies which have said cardiovascular and the stroke effects, and it has been a very, very useful thing in clinical practice to show that the blood pressure variability is an important factor. But the reverse is a bit of a problem. There is no study that really documented and said reduction of variability is beneficial. This is a catch-22 situation. You really don't know. But if you have a variability, there is a problem. If you don't have variability, is it not a problem? You're not very sure. But I think in clinical practice, I think it does make a difference. It's only a question of time before we land up with some kind of study showing this. Studies are not being done much because this is time-consuming study, and probably we should have somebody, if you are into research, probably you should consider doing this, and we should be able to come up with an answer to this particular question. This is going to be one. Now, how many of you have been sitting with your mobiles like this, and working with your mobiles. But the biggest thing that we've been doing over the lockdown is this: sitting with your mobile, seeing it most of the time like this. And this is what we've been doing. We've been having couch potatoes. Now, how many of you are practicing in clinics for sitting for more than 4 hours? Now, the implication is very, very simple. If you're going to be sitting for more than 4 hours, the mortality seems to be very high. So it is here. It is very, very clear that the mortality is much higher. How do I remove this out of my slide? Give me a sec. I just try to remove this. And this seems to be a little different. If you are going to be, give me a second. I'll try to get this out. Delete this and then sure. Yeah. Now you look at this particular person with less than 4 hours of sitting and more than 4 hours of sitting. As you sit for a longer time, the problem seems to be more. And it is more so if you're not physically active. If you're going to be sitting for more than 4 hours and if you're going to exercise for more than 150 minutes per week as recommended, the effect seems to be much less. So remember, if you're going to be sitting in a lockdown for sitting for more than 4 hours, 4 to 6 hours probably, which is the norm for most of us, maybe even 8 hours of 3 hours of watching a movie, 3 hours of watching the news, and probably another 2 hours of sitting and watching the mobile. You're going to be doing all that. It is going to be hazardous. Make sure you're going to be exercising adequately because the exercise seems to be overcoming this couch potato effect that seems to be there. We should never ever give up, but we should not allow the problem to defeat us. So I've given you a few problems that I noticed during teleconsultation over the last couple of weeks. What happened is, one of the complaints was this particular patient. This is on a teleconsultation. This is a photograph the patient sent me. They said that the patient has got leg swelling on both sides. A little bit of bleeding also from this. You can see the black marks. Now, you can do a video call and ask them to make them demonstrate pedal edema. I have done it. Now, what happens is you compress the shin 5 centimeters above the ankle, hold 15 seconds, keep showing it on the video. What happens? You'll definitely notice it. Now, this was just a photograph highlighted. Now, this patient was able to show this to me as an edema, and there was a significant pitting pedal edema. This patient happened to be on amlodipine for a very long time, and all I had to do was come down on the amlodipine and change over to an angiotensin receptor blockade after checking the gentleman's renal parameters. So you can demonstrate a lot of things. Patients are pretty smart, because they don't have anything else to do. You tell them online and tell them you just go do this, press it. And you can also demonstrate it. You can show it like this, press the shin like this. I usually do this. Press the shin, put one thumb, keep pressing, press for about 15 seconds and then release it. You'll show the swelling. You can easily demonstrate the edema. The second thing that I found out peculiar, I did it in one patient only, is this patient gets up from the lying down posture, he starts getting giddiness. Now it is quite simple. You just have to tell the patient clearly. You tell him, I'll give you 15 minutes time. You call me back in 15 minutes after doing this. Connect the BP cuff to the patient, make him lie down for 5 minutes, let the cuff be there. At the end of 5 minutes, check the blood pressure. Now let the gentleman stand. Once he stands, wait for 3 minutes, don't remove the cuff. At the end of 3 minutes, check the blood pressure and report back to me. You're diagnosed of orthostatic hypotension. Now it seems to be far-fetched, but I think what I have noticed is most of the patients seem to be understanding, provided you tell them that this is the way you do it. So I was able to demonstrate postural hypotension, and in fact, that patient was on some nitrates, and I was able to come down on the nitrates, reduce the drugs a little bit, and reduce the diuretics, ask him to slightly increase his fluid intake also. It really seemed to work. And you can manage all these patients much more clearly, and it works. The most difficult patients to treat are the elderly. They think they're strong, they're great. They are strong, they are great. But the point is, the way to tackle them is a little different from the conventional hypertensive patients. So here's a 79-year-old gentleman, known case of hypertension with a blood pressure of 180 over 110 millimeters. That was the blood pressure that he recorded today, and immediately he called me. It was an olmesartan 40 and an indapamide sustained rate of 1.5 milligram. We're dealing with two issues. One, he's an elderly gentleman. Two, you have a sudden rise in blood pressure. Now, how do you tackle sudden rise in blood pressure? Now, this is the same, but the elderly are actually classified as the young old and the old, or the old and the very old. If you're more than 65, you're old, and if you're more than 80, you become the very old. In principle, generally, if you want to start an antihypertensive, start with monotherapy, or if you need a combination, start with the combination of the lowest doses and watch out for postural hypotension, which I already explained to you. The goal blood pressure actually may not be the same, and the tolerated blood pressure might be different. You actually have to go for the tolerated blood pressure and not for the optimal or the goal blood pressure. You have to compromise a little depending on how the patient tolerates it in the very old. Now, this is the European Society of Cardiology 2018 guideline. And if you look at the diagnosis of hypertension up to 80 years, the systolic OFF-BP threshold is 140. But look at the more than 80, the third row, you will see that a blood pressure of 160 is accepted for medication. So if your age is more than 80 years, up to 160 millimeters of mercury, you don't have to start them on medication. And if it goes more than 160, you don't try to achieve an ideal blood pressure. Try to target 140, not the 130 like that. Even a 150 blood pressure is fair enough if they tolerate it. And if you can bring it down to 140, bring it down. But if you're already on a 130, patient tolerates it well, please don't reduce it. If they're tolerating and doing well, it seems to be right. But never bring it down less than 120. The second part that we're talking about is the 180 by 110 blood pressure. Now, if you're having an emergency and if you're having symptoms, you have to send the patient to the hospital. No point in trying to do a teleconsultation. If you don't have any symptoms, you ask them to rest, check the blood pressure again, 10 to 20 minutes of rest, check BP. And if the blood pressure is still high and they are symptomatic, still might be sensible to admit the patient. If not, you put them on a drug, like something like an amlodipine 10 milligram, or you can even give them an nifedipine if they are on a beta blocker. You give them this drug, ask them to check the blood pressure over 20 minutes. Your first target is a very simple 180, 110. 180, 110 minus if you're able to come, you can manage from home. If it's more than 180, 110 consistently, if you're not able to bring it down, the most sensible thing would be to probably admit him. Send him to the hospital for hospitalization. Teleconsultation is not a sensible thing to do. Because there are legal issues also involved here. It's not just a joke of just trying to control blood pressure with just numbers. You have to remember that you have to be very cautious in treating these patients. Treat them properly, not the way you should be thinking that you'll be treated. And if your blood pressure is not getting controlled, remember the 180, 110. If you're able to achieve less than 180, 110, follow them up probably the next day or within the next 7 days. You put them on some long-acting medication, either the angiotensin receptor blockade and a calcium channel blocker combination. Don't bring it down too fast. Put them on probably 1 or 2 drugs. Start one tonight, the one next day. I usually split them so that the initial effect is not added. The additive effect of 2 drugs added together is not there together. And then within about a day or 2, I ask them to check the blood pressure. It's an online consultation. It's much easier for the patient too. They're also very compliant. They don't have to come back from very far away. They don't have to travel in this and come back. They just have to check their blood pressure and get back to you. And the next time you do an online consultation, it just takes a minute or 2. So it's fairly simple and you can do it much, much simpler. And what happens is when you look at the target, if you're trying to treat them, never try to bring down the blood pressure less than 120, because especially in coronary artery disease or the elderly patients or those with stroke, if you try to bring down the blood pressure less than 120, there is cerebral perfusion comes down, the coronary perfusion comes down, especially diastolic comes less than 70. It's not going to be sensible, and cautious bringing down the blood pressure far too much also in these group of patients. But this is a slide that is very apt for the day. It just says, tempora mutantur e nos mutamur in ils. This is what exactly is happening. What does this mean? It's Greek, Latin. Yes, it is exactly the same. Tempora mutantur nos e mutamur in ils means times change and we change with them. I have learned a lot about how to manage hypertension in telemedicine. Patients teach us, we have learned, we have evolved, we are teaching ourselves. But what I think is, this is a very good way of following up these patients. Now, the point is, formerly patients used to call you and you never used to do a teleconsultation. Now you call them, give an appointment, spend 10 to 15 minutes with the patient and you charge them for it. It is a Pakka online consultation. It actually is cheaper for the patient because the patient doesn't have to come. The patient doesn't have to waste time. So it just takes 10 minutes of his time, even in his office or house or wherever he is. It is much more convenient for the patient and for the doctor. You allocate some time, and I think this has come to stay. So there are 4 categories of hypertension that keep happening. There is a masked uncontrolled hypertension, which is called the MUCH, white coat uncontrolled hypertension, which is the WUCH, and the sustained uncontrolled hypertension. Now, I did not touch much on the sustained uncontrolled hypertension, but I just want to tell you, the sustained uncontrolled hypertensions are mostly the resistant hypertensive patients. The resistant hypertension, I just want to give you a gist of how to treat them. You diagnose resistant hypertension if you're not able to achieve a controlled blood pressure with 3 drugs at optimal doses: the calcium channel blocker, the ACE inhibitor or ARB, and a diuretic. All 3 drugs, if you're not able to achieve, you diagnose resistant hypertension. This is quite common in clinical practice. Nearly a third of these patients are actually resistant hypertensive. There is also a very interesting term called masked uncontrolled hypertension, wherein 1/3 of patients which we think are controlled are actually not controlled. So there is a huge chunk of resistant hypertensive. The protocol for management as an outpatient is very, very simple. You really don't have to see the patient. In a resistant hypertension, the first thing you do is look at serum potassium. Patient can do an electrolytes and send it across to you. If your serum potassium is less than 4.5, the next step is to add a spironolactone, because 20 to 25% of these patients have a primary hyperaldosteronism. So spironolactone works in that. If your potassium is more than 4.5, don't add the spironolactone, because actually they're prone for hyperkalemia. You look at the heart rate. If the heart rate is high, start them on a beta blocker. If the heart rate is low, start them on an alpha blocker. All other drugs fall down below this. So remember, this is the protocol for management of hypertension, resistant hypertension too. This is going to work in clinical practice. So we have known how to manage hypertension also in this. So the points to ponder in hypertension, especially in clinical practice in an online consultation, your optimal blood pressure is 120/80. Anybody more than a 120/80, start them on a lifestyle modification. Even if it's a white coat hypertension, start them on a lifestyle modification. Your definition to start drugs, I think, is going to be 140/90. Remember 160/90 for the elderly more than 80 years of age. 130/80 to 160/100, it is fair enough to try a 3 months of lifestyle modification. But sometimes if you have an end organ damage, or if you notice that the renal parameters right, may be sensible to start them on medication. Look at a combination therapy if you're looking at a more than 10 millimeter reduction in blood pressure. Remember, there is an entity called MAST hypertension and a white coat hypertension. These are very useful in clinical practice. Finally, about telemedicine in systemic hypertension. It's a very, very feasible thing. We've been doing it over the last 1 month. We have seen close to 200 patients. Most of our patients, like I said, already do home BP monitoring, so it makes our life easier. We never thought the COVID is coming or the lockdown is coming, but that has been our practice. In fact, most of our hypertensive patients, even in regular clinical practice, we ask them to buy a BP apparatus. We give the chart that we showed you, and once we put them on the chart, we tell them if there is a problem, come back to us. Otherwise, come back to us after 1 year. And when you come back to us, you do all these routine blood investigations for hypertension, and then we will see you with an ECG and then consult you at that particular time. This is how we do it, and it's a very feasible thing. Home BP monitoring, and once they do start doing a telemedicine, I think it is going to be easier if you can ask the patient to come back to you after 3 months of BP charting or 6 months of BP charting. It makes it easier for both of us. For the patient is happy, doctor is happy. Because sometimes when you let the long gap for the patients, they are less compliant. It just happened in some patients. So you probably have to keep them on a leash and treat them a little more specifically. And teleconsultation, in my opinion, is here to stay. What I am looking at for the future is it is going to stay. Make the most of it, teach most of the patients about telemedicine, and make it a habit, not only now, even after the COVID days. I think this is going to make life easier, and I have a feeling that this is going to be the future, and we are going to be seeing about at least initially 20 to 30% of patients telemedicine permanently, and I wouldn't be surprised even if I'm going to be seeing 50% of the patients. Currently, all our patients undergo telemedicine or the teleconsultation, and then we see them physically. Maybe beyond a point when the pandemic is less, we are going to be seeing more of these patients. I will close with a small story about the elephant that happened to be there in a New York circus. I keep telling this very often because of this. A guy went to the New York circus, and when he went to the circus, this is a newspaper reporter, he was very thrilled at being allowed into the circus. He saw the lions in a cage. He was extremely happy. It was not the Alex that we see in the movie of Madagascar, the real lion that was there. Then he saw the monkeys chattering here and there, the busy ones, and he saw some peacocks, then he saw the tigers, and finally, when he went to the inside, he saw the elephant. But the moment he saw the elephant was actually tied to a rope. He got alarmed and scared and ran to the manager and said, "Man, are you trying to kill people in New York? If the elephant runs amok in New York, you're going to have a lot of people dying." He said, "No, man, don't worry, nothing is going to happen." He said, "Why? What happened?" When the elephant was small, we used to tie it to this rope, and it tried its best to pull it and realize that it can't break free. So what happened? It's got a mindset that when this rope is tied, it can't get loose. So even now, when it is tied to the same rope, though it is powerful and if it, with one tug it can come, it is not doing it because the moment it sees the rope, it's got a mental blockade, and I think she's blocked herself and not doing it. I think, ladies and gentlemen, dear friends, this is what is happening. The elephant is held back not by the rope, but by his thought. I don't think we should be held back by our thoughts of a clinic consultation. I think we should be going for an online consultation. We should be looking at the future, and I think we should be thinking more about how best to serve our patients, utilize the opportunity, come up and start doing something. I think I should thank the sponsors, the organizers for helping me out in this, and also to all the participants for very, very, very patient listening. And thank you very, very much for being with me. Now, I think if there are going to be any questions, we'll take questions. I will stop the share and come to the questions at this point of time. Do we have any questions?
Thank you, Doctor. There are few questions. Shall I read it out for you, sir?
Yeah, go ahead.
Yeah. Dr. Sujeev has a question. He says, sir, how to treat diastolic hypertension 130 by 100 millimeter of mercury? That
Sir,
is his question.
this is more or less similar to the patient that I discussed. If you're going to have a teleconsultation, it's different. But if you're going to have a 130 by 100, today the drug of choice is going to be an ACE inhibitor or an ARB if the patient is less than 55. More than 55, the calcium channel blockers work better because the mechanisms of hypertension are different. I didn't have time to talk about it, about all the mechanisms of action. But if the age is more than 55, there it is more of arteriosclerosis. The vessel wall becomes thickened, and the calcium channel blockers, the diuretics, work much better beyond that age. But your patient, considering that he is going to be 130 by 100, I should presume that he's a youngster. Look at the heart rate also. If the heart rate is pretty high, probably a huge component of anxiety is also there. So be a little cautious with that. And probably the best first drug for any person would be a patient who's started on an ACE or an ARB. But before that, like I said, always do confirm your blood pressure, make sure he's hypertensive, start him on a lifestyle modification. And the best time to encourage a patient to do a home BP monitoring is at diagnosis. And you also tell him that if you do a home BP monitoring and you are not going to be on medication if it is fine, that encourages him to buy a blood pressure, which is blood pressure apparatus, which he can keep it throughout his life and keep monitoring blood pressure. These machines last quite a lot, but they can be calibrated fairly okay because nowadays there are plenty of these machines available, and there are a lot of people who do these calibrations and it can be done. But I think I should have answered your question. First, make sure that you're hypertensive and then start treating these patients. Best drug for hypertension variability. Sir, Dr. Sujeev's question. Is that the next question?
Yes, sir. That's the next question.
If your hypertension variability is there, the drug that has shown the least hypertension variability has been a calcium channel blocker, the lowest. Probably the ARBs and the ACE inhibitors come next. That the best drug so far has been the drug that has been showing a hypertension variability has been the calcium channel blocker, and that's probably the best drug for reducing the hypertension variability. Pseudo-hypertension is because of faulty measurement of blood pressure. The faulty measurement of blood pressure, the commonest thing that we do is you use the wrong size cuff. Obese lady with a small cuff, you don't have the extra large size cuff that you have, and you measure a blood pressure, or your patient comes to your clinic, you're in a hurry, patient in a hurry, put him down in a chair and check the blood pressure immediately. The wrong technique of measuring blood pressure, that is pseudo-hypertension. This can be overcome if you use the right size cuff most of the time, and the technique that I asked you. You make the patient sit, back supported, leg flat on the ground, and the elbow rested on the table, give him 5 minutes of rest. And then after 5 minutes of rest, you check the first blood pressure, 1 minute later the second, and another minute later the third, and that's when you're going to get the correct blood pressure. That is going to be diagnosing the correct blood pressure. But this is a very common cause of resistant hypertension also, and that's very important to look at in resistant, because most of the patients that are these obese fat women that keep coming with resistant hypertension, it's very common in obese elderly women. They have arms that are like this big, and those hands, you really can't fit a BP cup. I do have an extra large BP cup which I can do it, and most of the time you'll be surprised that their blood pressures are actually normal. Because of the wrong cup, their blood pressures have been falsely elevated, and if you don't have it, the alternative that I keep telling is, as a consultant, don't tell the patient, don't ask the patient to do it, but as a consultant, what you can do is, if you don't have anything else to do, you can still use the wrist blood pressure. Though it's not the most accurate way of doing it, it's a much better way than actually checking it up and making somebody hold the cup like this. 2 people holding it, that's all wrong method of doing it. Put it in the cuff, try to auscultate the radial artery, you get a much better estimate of the blood pressure in these group of patients.
Okay. Sir, there was one more question from Dr. Veera. He says, awesome presentation, sir. In the recent guidelines, they have recommended to measure BP in both the hands simultaneously, but we have been measuring it only one after the other. Are you practicing the simultaneous measurement way, sir? Your comments on that.
Excellent question. I don't know where Veera is from. It's a very good question. I didn't touch on it. Basically, because I was just focusing more on the telemedicine part of it. I didn't touch it. It's a very good question. So what you tell the patient is, first time when you measure the blood pressure, measure in both arms. Now, if you're going to have a more than 10 millimeter BP change between the two arms, check it up in the arm that is got the maximum blood pressure. The higher pressure is the correct blood pressure because the other one is not transmitting the cardiac pressure. The higher one is always the correct pressure. So the first time when you measure, do it. If not, it is different. Now, I have had times where I have actually missed in the past. Because first time, whenever I diagnose hypertension, because I have the privilege of having a secretary checking my blood pressure, because I make them sit in a room separately, and there my secretary puts a BP cuff which records 3 blood pressure. There are a couple of apparatus that are available which measure 3 times and give you an average of the 3. So I have that. So what I tell them, if it's a new patient, check on both limbs and they write it down. So before the patient comes to me, it comes with 5 minutes of rest in both arms. So that I have the privilege. But if you want to check it up, at least in newly diagnosed hypertensives, do this. Now the other thing is, if you have somebody who says that his blood pressure is sometimes 160 and sometimes it is 120, then you start suspecting. You ask him, where was this check? Where was this check? He says, no, I went to the hospital, they checked it here. In my house, it is 120. Then you start looking at the BP in 2 different arms. I had actually one patient like this who actually had an aorta arteritis. So sometimes you diagnose it when the patient says the fluctuations are wide. So that also happens. But in clinical practice, you're absolutely correct that this is the way to check blood pressure.
Okay. Same doctor has one more question. When some patients complains of postural giddiness only, we have been measuring the standing and sitting BPs. We aren't measuring the standing BP for everyone. What's your practice, sir, and your comments on that?
My practice is I don't measure unless the patient complains. Because the patient's complaint is important. If the patient complains of postural giddiness in clinic, I used to do what exactly I said for the patient also. Make them lie down for 5 minutes, put the cuff, make them lie down for 5 minutes, let them relax, take it easy, then check your blood pressure, 3 minutes of standing. In fact, I do one within about 30 seconds of standing and 3 minutes of standing in my clinic. And that is only when they have postural hypotension. So this postural hypotension is pretty important, especially in diabetics because of the autonomic neuropathy. But routinely, do I do it? No. Because sometimes it takes time. Patients get a little worried. They want to know what happened. When the symptomatic, you ask them to do it, it works pretty handy. But otherwise, I don't do it in routine clinical practice.
Okay. Fine. So there's one case study kind of a thing. I mean, the doctor says a 38-year-old male having giddiness and palpitations 1 month back. Office BP was 150 by 100. Cardiologist prescribed metoprolol 100 milligram. He says, can we stop metoprolol, put him on low salt diet and lifestyle modifications and with home BP monitoring?
My first question is, did you stop the metoprolol 100 milligram? Please don't do. If the patient is on a beta blocker, first thing is, if you withdraw the beta blocker, especially 100 milligram once a day, 100 milligrams of metoprolol, if you withdraw, you're going to get the deep trouble. Because whenever a beta blocker, it's not the right drug of choice unless there is a significant high tachycardia, anxiety component involved and things like that. I don't think anybody would have prescribed a beta blocker of such a high dose. But generally, when you withdraw beta blockers, be cautious, go slow. Even if you want to do a lifestyle modification, start the lifestyle modification, probably reduce the metoprolol from 100 to 50 and probably 25 and then try to get it off. Because most of the time when you try to withdraw the beta blocker abruptly, patient lands up with headache, palpitations and all kinds of symptoms and you are in deep trouble. And the patient will go back to the same drug and patient will probably not come back to you. So be cautious when you withdraw the beta blocker. But I agree with what you're saying. With the 150-100, what technique that you're talking about, especially the diet and lifestyle modification, low salt diet and home BP monitoring is a much better choice. Probably it should have been done. But in clinical practice, what we notice is most of the time we want to solve the problem immediately. We don't really believe in that. But see, the key is this. You tell the patient at the first time diagnosis of hypertension, we give you 1.5 or 3 months time and you do it. If you bring down the blood pressure with a good set of things, we don't start you on medication. But if you are not able to, then I will start you on medication. So I give him the choice. You are given the first choice. You try to change it, it's going to be wonderful. But if you can't do it, then we change it. That is going to be the answer. So I think that's the way it should be looked at. And if you look at it that way, your choice is good, but don't withdraw the beta blockers abruptly and very fast. Be a little cautious on that.
Okay. Question from Dr. Vasantan Vamadevan. How to identify and act upon possible or actual end organ damage during teleconsultation of a patient with markedly high BP?
Vasantan is sitting in UK and troubling me from there. He used to ask a lot of questions in India. Now he's going to UK, he's not leaving me alone. These questions are always troublesome and he's not changed a little bit either. Now, you tell me how are you going to do it? There's no way you can do a fundoscopy, but you can take an ECG and look at left ventricular hypertrophy. That is possible. And if you are thinking that the patient has got an uncontrolled hypertension, like I said, telemedicine has its limitations. Like if you are okay, you could still get the patient for echocardiogram to look at left ventricular hypertrophy, because if you feel that the blood pressure is not getting controlled or there is going to be a lot of fluctuation, you think that the patient is not recording BP, you can still get the patient out. But beyond electrocardiogram, you're not going to do. One end organ damage you can look at is you can look at the urine albumin creatinine ratio, kidney affecting, you can see. Fundus, there's no way you're going to see, but echocardiogram can be done with a little bit of touch. I showed you a picture of how the echocardiogram is done in my clinic, so I think that is possible there. And I think that is it's a little difficult thing, but I don't think you can win everything in teleconsultation. There are some limitations. It's not the perfect way, but I think for hypertension, teleconsultation offers a lot of scope. I think we should be doing more of teleconsultation for hypertension, and that's what I'm telling. What I think is that this is a big eye-opener. COVID, I think, is a big eye-opener in terms of clinical practice, and I am actually looking forward to a lot of teleconsultation in the future, because over the last 1 month, we have done, like I said, about 200 patients, and I feel pretty comfortable with that. But the key is your secretary. That, I think, is very important. You need a good person who's going to handle the appointments, explain it to the patients, tell how it works, follow it up. And so if they don't do it, you're going to end up spending about 20 minutes with the patient. Now, when you're having a good person who's going to handle the show, you're going to spend about just 10 to 15 minutes like in a regular consultation, wherein you're going to be talking sense, you have more time to explain things to your patients, and actually patients are very, very satisfied in a teleconsultation. I think that's a way to look at it in future. And I think that kind of sums it up. There's one further question that's landed up there finally. Is there one?
We are asked a question. Yeah, there are no more questions. Of course, some of the doctors like Asha Murthy has appreciated your talk. Dr. Ilayaraja says a very impressive lockdown profile. That's what he's saying. But I have a question, sir. Since you say you have been practicing telemedicine, that's in your own method. A lot of platforms are available to do telemedicine, right? So you would suggest that those platforms are useful, or you continue with the doctor's best method, whatever he can do it?
No, my problem is we already have an electronic medical record in my clinic, which is cloud-based. So I can access it from here. My secretary accesses it from her home. So we sit in two different places and we coordinate on the telephone. And in fact, there are times when we are both connected on Zoom. So I know what she's doing and I know she knows what I'm doing. So we are connected on Zoom so that we are linked up. And ours is, I think, it's like I said, it's my own self-styled profile that works, and that's how it goes. But what happens is, if you go for any of these platforms, you have to start from scratch. And most of the platforms, I actually went into the platform to see how it works. Most of it, what it does is it lets your secretary just key in the basic data of the patient. Now, after that, you are on consultation and you have to fill in the entire case sheet as you keep talking to the patient. If you're going to have an assistant who's going to be doing it, well and good. If you're not having an assistant, if you're going to do a teleconsultation on your own, you're going to be in a whole lot of trouble, because it's going to take time and you're going to do this, do that. And how is the patient going to record blood pressure? How is the patient going to record this, record that? Now, if you have somebody else doing it, if you have two people doing it simultaneously, you have a lot of things that are already tailored for you and it works. The last point about the online platforms is, all these online platforms, they take a 10 to 20% service charge out of your fees. You don't have to pay anybody. In fact, what we do is we take a direct transfer like what we do in my clinic. And that is another small bit of advantage. But I think the overall picture is that when you do an online consultation in your own style with your own electronic medical records, it makes it easier. If you start running an electronic medical record for the first time, you want to start any of the online platforms, look at any of those and find out which is going to give you a cloud and which is going to be the right thing for a later analysis of your data. Because with our 6,000 data is about 6 years data is what we did our presentation. One of our papers is actually based on that. So you can sit down during a lockdown also and start working on your patients, collect the data and start doing work. That way it's pretty useful. I think I should thank everybody for such a patient hearing. I don't think there is any further questions. Thank you very much. With one last word about teleconsultation and hypertension. It's here to stay. Utilize it, learn it, and please start using it for future. It's going to be very useful in clinical practice. It saves you a lot of time. Thank you very much.
So there's one last question which has come up. Should I read it for you, sir?
Yeah, go ahead. Go ahead.
What is your comment? What's your comment on Azilsartan for salt-sensitive patients? Dr. Sujir is asking this.
It does work. Azilsartan works well. Azilsartan is one of the very good drugs that brings down near close to double-digit reduction, or near 20 millimeter reduction in blood pressure, and in combination with a good diuretic, it works much better. So it's a pretty good drug. It's pretty effective. And in salt-sensitive patient, how are you going to diagnose a salt-sensitive? That's a big question, and it's a separate topic on its own. Probably we'll have a separate webinar on that. But if the patient is salt-sensitive, Azilsartan works pretty well in these group of patients. And if you're going to identify it, it is pretty effective. That's a separate topic, and it's been proven to be very useful in these group of patients. I don't think it's a class effect mentioned for all the ARBs, but Azilsartan, there is some data which says that in salt-sensitive patients, it is pretty effective.
Okay. So I think no more questions. So, sir, thank you very much. An excellent, lucid presentation, a lot of informative, and of course, our participant doctors are happy about it. So, thank you very much, sir, for having spared your valuable time. And on behalf of Microlabs, I take this opportunity, to have for you having been on board with us, and from Rajkumar also. Thank you very much, sir.
Thank you, sir. Thank you for the opportunity given, sir. Thank you, sir.
Thank you. Thanks for that.
Thank you, sir.
So with your permission, sir, I am closing the meeting.
Yeah, thanks.
Thank you.
You can stop the recording.